Thank you, Chairman, for kind introduction. Good morning, ladies and gentlemen. I'm Choi from Seventh Cardiovascular Hospital, Seoul, Korea. My talk is about indications of percutaneous PDA closure in premature infants. It is very well known that PDAs are frequently associated in premature infants, and hemodynamically significant PDA increase the risk of chronic lung disease, prolonged assisted ventilation, pulmonary hemorrhage, bronchopulmonary dysplasia, and intraventricular hemorrhage, renal impairment, necrotizing enterocolitis, and even death. So the association of PDA in premature infants and the respiratory or other morbidities have been described since 1950s. So the hemodynamically significant PDA in preterm infants causes a pulmonary overcirculation with the resultant the pulmonary edema and pulmonary arterial hypertension, and pulmonary hemorrhage, prolonged assisted ventilation, bronchopulmonary dysplasia. Also, the systemic hypoperfusion due to the PDA may cause some necrotizing enterocolitis, renal impairment. Also, altered brain, the hemodynamics may cause some intraventricular hemorrhage. Treatment options for PDA in premature infants include conservative treatment with fluid restriction, diuretics, and also increasing the positive and the expiratory pressure may decrease the amount of left uteration and helps to maintain the cerebral perfusion. Also, during the conservative treatment, it may be expected for the PDA spontaneous close. Pharmacological closure started since 1967, and it is as the prophylactic treatment immediately after the birth, and also early targeted treatment for hemodynamically significant PDA during the first week of life, and later treatment for symptomatic and hemodynamically significant PDA using indomethacin, ibuprofen, and acetaminophen. Effectively, it is known that this pharmacological agent effectively close PDA without invasive treatment, and also it can be repeated as a second course when first course was unsuccessful. There may be a potential adverse effect, including renal dysfunction, necrotizing enterocolitis, or GI perforation. There is no consensus on standard treatment. However, a recent study suggested that the high dose ibuprofen may be more effective, which is started at least 3 to 5 days afterwards. Surgical ligation have been actively performed since 1970s, also associated with adverse effect, just like LV dysfunction, Fregner palsy, buccal cord palsy, and possibly increase the incidence of BPD. Transcatheter closure is the relatively recently evolved option with some advantage over other treatment. However, even with the well-known efficacy of a pharmacological treatment and also surgical ligation, some investigators had some doubt on the role of some active closure of PDA. So randomized trials and meta-analysis revealed that there is no evidence for short or long-term benefits to close PDA in preterm infants, and early routine treatment to close the PDA in preterm infants does not lead to better outcomes. So the conservative treatment gained momentum as a main treatment modality from mid-2000s, and more neonatologists were unsure of potential benefits of PDA closure. so which results in the significant decrease in pharmacotherapy and surgical ligation in especially United States since mid-2000s. However, this should be interpreted with caution because this null hypothesis, based on old studies with a different therapeutic environment than current status, and also in those studies, there is a large proportion of a control arm crossed over to treatment, and these the studies, many of these studies performed without echo, without verification of a significance of a PDA, and without enrollment of high-risk patients, also without the baseline criteria on need for oxygen or mechanical ventilation. So those findings have some limitation to reliably applicable to current the practice. So the PDA closure in premature infants, active treatment for PDA closure may be indicated in any symptomatic premature infants with hemodynamically significant PDA and at risk of the PDA-associated complications. Indications and timing for PDA closure in especially extremely low birth weight infants, high-risk infants, remain controversial. So many investigators thought that the classification schemes may be helpful to predict and characterize the hemodynamically significant PDA, and also efforts to minimize potential adverse effects associated with the modalities to close PDA are important. So what is the hemodynamically significant PDA? To define the hemodynamically significant PDA, the multidimensional evaluation is required. Clinical indicators including demographic parameters, current clinical status, need for respiratory support, including mechanical ventilation and feeding intolerance, abdominal distension resembling necrotizing enterocolitis, and renal function impairment, hemodynamic instability, and metabolic acidosis. Also, echocardiographic parameters are important, including transductal diameter and left heart volume overloading, and some LA to aortic dimension ratio, and the peak velocity in the PDA. Also decreased or reversed diastolic flow in descending or descending aorta or the cerebral arteries. Also, the risk of adverse outcomes should be considered, including high-risk premature infants and other individual risk factors. This slide shows PDA staging system, including the clinical criteria and echocardiographic criteria. Clinical criteria includes oxygenation difficulty, oxygen desaturation, and some ventilatory assist requirements, and some feeding difficulty, and renal function, and also some systemic hypotension and metabolic acidosis. Also, echocardiographic criteria include ductal diameter, unrestricted pulsatile transductal flow, and also status of volume overload, and some reversal of the end diastolic flow in descending aorta. This is another system describing determinants of risk for preterm infants, including symptoms and signs of tachycardia and tachypnea, respiratory support, abdominal signs, and signs of organic dysfunction, and also, importantly, echocardiographic parameters. So indication of invasive PDA closure should be symptomatic premature infants with hemodynamically significant PDA with the presence of contraindications to medical therapy or with the failure of medical treatment. The decision making should be based on the consensus among the treating neonatologist and the pediatric interventional cardiologist. So this slide summarizes the indications and the expert recommendation of transcatheter closure of PDA. So indications and knowing the contraindication is also important. Indications include, this is some criteria for some FDA approval for the Piccolo device. Age 3 days of life is important because of too early treatment reported to be not beneficial. And the weight 700 grams. Hemodynamically significant PDA, clinical and echocardiographic with clinical and echocardiographic criteria, failure of or contraindication to medical therapy, and if this procedure should be performed in the cardiac cath lab, the stable transport should be is important, also important. Contraindication include procedural weight, minimum ductal diameter, too large the duct, and the too short duct, and the presence of coarctation of LP stenosis, which may be aggravated after device placement, and the absolute contraindication may be active infection or pulmonary hypertension with right atrial shunt, and also duct-dependent congenital heart disease. This slide shows some consensus of the experts. So the less than 28 weeks of gestational age and some size more than 2.5 millimeter, and after 10 days of postnatal or 10 to 11 days of invasive mechanical ventilation is appropriate, so to be appropriate for the transcatheter closure from the current expert opinion. Also, the institutional experience should be considered and with this recommendation. Then, when is the optimal timing for PDA closure? There is some lacking of consensus on timing of transcatheter closure. Earlier closure less than 4 weeks is associated with improved outcomes, and if the closure is achieved too late, over than the 8 weeks of life, then pulmonary hypertension may be more prevalent. So the PDA closure should not be postponed later to the 4 weeks or later. So this slide also shows that a study suggesting that definitive PDA shunt elimination may be considered beyond 10 days postnatal age or after 10 to 11 days of invasive mechanical ventilation because of some previous evidence from previous studies. Then what about the Percutaneous closure and surgical closure? In the United States, there is a trend over the decrease of the surgical ligation and the increased trend of transcatheter closure. And also the studies on comparison of percutaneous closure and surgical closure revealed that the substantial reduction in all-cause mortality and the hemodynamic instability with transcatheter intervention compared to surgical closures. So better outcome from the percutaneous closure, and also the survival is improved, and the neonatal complication of length of stay decreased with transcatheter closure, and the more use of with the trend of more use of transcatheter closure. There may be some issues which should be clarified in the future study, including patient selection, which population will benefit from the treatment, optimal timing of intervention, how to minimize adverse effect of intervention, and also individualization of treatment strategy in each patient. Thank you very much for your kind attention.